All right, well, hello everyone. My name is Michelle Werner. So I'm the respiratory therapist at Froedtert. I come right now only to the Thursday ALS clinics. We used to have someone come to the Wednesdays and we're hoping to get that back soon. But I do not work Wednesdays right now. So it'll be somebody new when we do get that back. But I've been at Froedtert in the pulmonary function lab for 9 years. I've been coming to the ALS clinic since right before COVID started. So just, I guess, a little over 4 years now. I guess that's about it. I've been a respiratory therapist for about 14 years total, but I've been here for 9. All right, so I'm going to talk about different aspects of respiratory care with ALS, equipment, the testing, just general physiology and things like that. Okay, I got to figure out how to go to the next screen. Hold on. Okay. So my agenda here, respiratory issues with ALS, the pulmonary function testing that we do in clinic and then also in our lab, and then different breathing exercises that can be good, and then lastly, the equipment that can be supportive with these issues. So I'm gonna, sorry, okay. So the respiratory issues with ALS causes weakness in many of the muscles, including the ones that help you breathe in and out. So the ones that kind of surround the lungs and the diaphragm and things like that. The symptom management is the major component of the care of ALS. Just kind of make it more comfortable for you to breathe, different aspects like that. So the short things that can be common with ALS with your breathing is it can be more common to get more short of breath doing normal activities than you were before. Even just not doing activities, it is more common to be short of breath, just because the muscles are not keeping up with the breathing as well. Sleeping, it can be hard to sleep on your back, or it can be more, you can get more short of breath with ALS. Just even if it feels like you're sleeping okay, your muscles are usually working harder to help you breathe than they otherwise were. And it's also pretty common to have a weakened cough. Does not happen with everybody, but it does. It can be, your cough can get weaker and it can get harder to clear secretions and things down in your lungs than you otherwise were able to do before. Okay, so the testing that we do in clinic and also up in my lab, the pulmonary function testing, the one that we do in clinic is called spirometry. It's the most common pulmonary function test that there is. It just gets the most information from one test. It measures the airflow and how much air is exhaled, like the volume of air, and then how fast or the speed that it's exhaled at. The number, spirometry can get a bunch of different values that tell them about your breathing. The one that we look at the most with ALS is called your FVC, or your forced vital capacity. And that's the number that I tell you in clinic when we do this test. It's the most important breathing measure for ALS. It measures the volume of air exhaled with a full exhalation forcefully. So it gives each person a percentage of how much air you exhale compared to what someone like you should be able to exhale. So someone your age and your height and your gender and your race all go into a part of that. So nobody should exhale the same or inhale and exhale the same amount of air. It'll be different for everybody. And we have a reference set that compares how much you do compared to what someone like you should do. And then it gives a percentage. Sorry. So that is the number that we look the most at in the clinic here. There's other values that the spirometry measures that they look at as well. There's one, I don't have it on here, but it's called the FEV1. If you've seen these numbers before, that measures the forced amount of volume of air exhaled in the first second when you blow out really hard. And that tells them kind of how open your airways are, but it won't give them a measure of the lung capacity like the FVC will. But those are the main two numbers that they look at when you do this test. Okay. If you do, so we do that test in clinic. We also sometimes do the spirometry in clinic laying down. We call that supine spirometry. And that I can do that on clinic if they need to look at that number, and if you're able to lay back either in a wheelchair or on the exam table. So we can do spirometry in the supine position, laying back on your back. And that is where when you're on your back like that, and we do that test, your diaphragm kicks in more when you're on your back. And that is what they're looking for if the doctor asks us to do that test laying down. They're looking for the involvement of the diaphragm. So the number should be less than the number sitting. But if it is a big difference between the number sitting up, then it tells them that your diaphragm is not kicking in to help push that air out. So the spirometry and the laying down spirometry are the two that we can do in clinic. But sometimes they need more testing done to either qualify for different equipment or just to get a greater picture of what your lungs are doing. In that case, they would refer you to our pulmonary function lab, where we can do testing with our machines more than what I can do on that portable one. So the main other test that we can do in the lab is called your MIP and your MEP. It's your maximum inspiratory pressure is the MIP, and the maximum expiratory pressure is the MEP. Sounds very similar, but that test, we look at the pressures that you can forcefully create when you're breathing against like a resistance. So in our lab, we do that test. So the first one, the maximum inspiratory pressure, you're breathing against a resistance when you breathe in. The machine that we use makes it harder for you to pull that air in through your mouth, and they want to see the pressure created when you pull that air in. And then the opposite, the maximum expiratory pressure, when you blow out really hard, kind of like you do for the spirometry in clinic, but you're blowing out against a resistance, and then the machine records the pressure at which you can kind of push through that resistance. And so they use those numbers just to get a little more clear idea of what your lungs are doing, but also if you need to qualify or want to qualify for some like a BiPAP or CPAP, non-invasive ventilation, and your spirometry numbers aren't quite there to qualify you. They will sometimes do these other tests to try and qualify that way through the insurance companies and everything. So the pressure test will usually kind of create lower numbers just because you really need a good force to push through that resistance in and out. And then I have on here the spirometry upright versus supine, which I was just talking about. We used to not do that in ALS clinic, but we can now with another software on my machine. So they used to send you up to our lab to get that done, but we can do that in ALS clinic now as well. So that one, you wouldn't, if they just wanted to see that, we wouldn't have to go up to my lab for that. Okay. So I already talked about this on the other screen, but the pressure test that I was just talking about, the MIP measures the strength of the respiratory muscles that are used during inhalation and exhalation. So with the inspiratory pressures, the procedure that you would go through on the machine is you would have the mouthpiece in your mouth and you'd exhale completely, like all the air. And then when I would tell you to, you would inhale really quickly with as much force as possible, but you're inhaling it against a resistance or an occlusion like I have there. So it's going to kind of create, the pressure that it takes for you to move that air against that resistance. And then the opposite, the expiratory pressure, to do the maneuver on the machine, you would inhale completely, just like you would with a spirometry that we do in clinic. But then when I tell you to exhale forcefully, it's going to be different than the spirometry because the air isn't going to just move out as nicely. It's going to be against a resistance, and you really have to use a little more muscle to push that air out against that resistance. So the spirometry upright versus supine, I was just talking about that as well. But we do the normal spirometry first. So sitting up like we do in clinic, where we do about 3 of them with your nose clipped. And then we take the best of those 3. And then we would do the spirometry again, but in the supine position, reclined on your back, either in a in a wheelchair that reclines, or on the exam table or another chair that can recline. And the spirometry in the supine position detects diaphragmatic weakness. So the weakness of your diaphragm, if it is not helping you breathe as well as it should. Okay. So complications of the pulmonary function testing that I do, it is sometimes hard to get good, accurate numbers with ALS being in the clinic. So the loss of facial muscle strength just makes it difficult to form a tight seal around the mouthpiece. So the normal mouthpiece that we use is like a circle. And sometimes that can be hard to really form your lips tightly around that, because we do need a tight seal around that, so all the air only goes into the mouthpiece and it doesn't come out around it. And then I do have that blue mouthpiece, if anybody's familiar with that one. It's more rubbery and it looks like a scuba diving mouthpiece. It covers the sides of your mouth a little bit better, so you don't have to form quite as good of a seal as you would with the regular mouthpiece. And that one it works better because you don't have to form that tight seal, but sometimes it can be hard to, with the loss of the facial muscle strength, to get that mouthpiece in your mouth exactly how it should be, and things like that. So even though that one's a little bit better, it still isn't, sometimes it just still doesn't make the test come out as it should, if we can't maneuver that mouthpiece in as we should have it. But just this year, I finally started using masks with my spirometry, which I've been trying to do for years. And that has really been, I feel like, a game changer, because a lot of people who weren't able to do the spirometry accurately with the mouthpieces have been able to do it with the mask, and we've been able to get better numbers like that. So the mask, it's on my same machine. I don't have a picture or anything, but it's on my same machine, and the mask is one that kind of blows up around the edges. It's similar to the mask that you would get with a cough assist if you have a cough assist machine. So with that mask, we kind of just hold it up around, it covers your nose and your mouth. We hold it up tightly and you're able to do the whole spirometry maneuver. You don't wear nose clips with that because we want the air to come out of your nose as well. And you don't have to work quite as hard to form a seal around any mouthpiece. So it's not 100% perfect, just because the air is kind of coming from a bigger area to go through that the machine, but it has been really helpful doing the test with people that we otherwise weren't able to do it on anymore. So that is one complication of the pulmonary function testing. Another one is called glottic closure. And you may have heard me say those words in clinic before, if this has happened with you. But the glottic closure is closing of the vocal cords during exhalation. And it kind of stops the flow suddenly before the lungs have completely exhaled. So it's kind of like a flap that closes, and your body normally keeps that flap open on its own. It's something that you don't even think about that you're doing it when you do it. And when you're talking and things like that, it would open it, but without the muscle strength, it's just something that your body is not able to open and close as it should anymore. And so when you're exhaling really forcefully, the glottis just closes and you can't get air out that you otherwise would have in there to get out. So it could make the forced vital capacity number be falsely reduced because we can't measure that air that's not coming out anymore. It's not something that you can control. And when it does happen, I do document it in the notes. So the doctor knows that number, otherwise your forced vital capacity otherwise would normally be higher. So those are two of the complications with the pulmonary function testing that we do. I'm gonna grab some water. So I'm gonna move on to the breathing exercises that are helpful with ALS, just to kind of get more air in the lungs and also kind of strengthen them. So the one that I teach the most in clinic is called breath stacking. It's my favorite one because you don't need any equipment for it. You just do it on your own. You can do it whenever you remember. It's a series of breaths that you take without exhaling the previous breath. So it's meant to interrupt a cycle of poor airway maintenance. So it's meant to, like, you're doing a bunch of shallow breathing without even thinking about it. And it's kind of meant to interrupt that cycle and really force you to take a deep breath in to expand your lungs really nicely. I'm going to see what my next slide in, okay. So the benefits of breath stacking. So let me go through what the maneuver is. So you're going to take in 3 to 4 breaths on top of the previous breath without letting that previous breath out. So once you get at the last breath or two at the top, kind of get really hard to take in because your lungs are already pretty filled. So you're gonna, and then hold it at the top for a few seconds and then let it out slowly. So my first 2 breaths were really easy for me to take in, and the last 2 were actually really hard, but it just makes you take a really good breath in, kind of expands your lungs down there. It also, if you're feeling anxious, can slow down your breathing because it's giving you, you're thinking about it more than you otherwise would. So the benefits of breath stacking, it increases your lung compliance. So just the flexibility of your lungs, and you're kind of really getting the edges of them to expand more than the other would, so they can hold more air. It increases the lung volume. So the amount of air that you're getting in your lungs, it's increasing because you're taking these breaths on top of one another. And it also improves the airway clearance. It can help with coughing, just kind of getting the strength it can help build back some of that. It's not going to build back all the strength, but it can just really help build a little bit of strength to just really try and take all those breaths in. You do need some strength with it. And that can help with kind of coughing and removing secretions from your airways as well. So you don't have to do it all day or anything, but when we do recommend it, we say do like 3 or 4 of them at once, a few times a day. So, morning, noon, and night, just when you remember. Don't need a for it, which is really nice. So you can do it when you're out or just doing anything. Another breathing exercise is this one uses a device called an expiratory muscle strength trainer, EMST. And so the device is pretty small, and it creates so you breathe, you exhale into the device, and it creates pressure or resistance while you're exhaling. And it has a thing on the end of it that you can turn to either decrease or increase the pressure. So if you start at a really low pressure when you're exhaling and you're getting really good at that, you can increase the pressure or turn the device and it'll increase the pressure a little bit. And then you can practice on that pressure for a little bit. So you can make it easier or harder for you to kind of train your muscles to really blow against that resistance. But it strengthens the muscles in the upper respiratory tract. So the intercostal muscles, which are the muscles kind of in your ribs area that surround the lungs. It helps muscles that move the vocal cords, and also the pharynx, larynx, and soft palate. So it kind of really just helps all the muscles up in the area, but also surrounding the lungs in your ribs area. It also, so it works by releasing the pressure while you exhale, which builds up the strength of those respiratory muscles. So you exhale into the device, and there's a pressure there, and you do have to push a little harder to get the air out because the pressure is right there at you. And you can increase and decrease that pressure as needed. me take a little more water. So those are the breathing exercises. Those are the main two that we go through in clinic. And now I'm going to move on to the supportive respiratory equipment that we recommend sometimes in clinic if it's needed. The benefits of the supportive equipment are that they create more energy for you. So even though if you feel like you're not working so hard to breathe, sometimes your body is just expending a little more energy just to breathe for you or to help you breathe. So the supportive equipment can kind of reduce your work of breathing while you're using it and then give you more energy when you're not using it, just because you weren't working so hard while you were on that equipment. It can have you sleep better just from not having to be short of breath at night while you're sleeping. And then it can also make you just feel more comfortable, get rid of some of those secretions, and then also just help you breathe a little easier. And then lastly, just can help you think more just by getting that air, like the CPAP and BiPAPs get the spread around the air a little better when you're wearing them, and it just kind of brings the oxygen to more of your organs and everything like that. So, okay. So the first piece of equipment I have here is called a suction machine. This is, I don't quite know if this is what they look like when you get them for home use. We used them in the hospital a lot, and it would look like something similar. So, but the suction machine is kind of just what it sounds. There's a mouthpiece that attaches to that blue adapter that you can see on the screen there, and it just sucks saliva secretions out of your mouth that you are unable to otherwise kind of get rid of yourself. Sometimes with ALS, you can have more saliva or secretions if you notice that, just because your body isn't able to like, normally you don't think about, I guess, how much saliva you produce, but it is quite a lot throughout the day, and your body just helps you swallow it whenever it needs to. But if your muscles aren't quite working the way they should up there, you just aren't able to swallow it as well. And that kind of can build up, and you want to get rid of it. So the suction machine is a good tool for that. It also can help you cough a little bit and get rid of phlegm if needed as well. So that is the first piece of equipment. Okay, so here I have just some more information on it. The suction is used to remove mucus and saliva when your ability to swallow can otherwise be impaired. It can breathe easier that way. It can decrease choking just from having so much saliva back there that you're trying to swallow, and generally just make you feel more comfortable without having that in there. The next piece of equipment is the cough assist machine. I know that these have been sometimes hard to get recently, and they've been on back order, and I know the one that's made through Philips, I think, was discontinued, and then there's another model that they're using now. And I don't actually order this equipment, so I don't know all the ins and outs of the different models and which one they're using. But I know that they were on back order for quite a while, but then recently people have been able to get them. So I'm hopeful that that problem is solved, but I guess I'm not too sure on where they are with that. But this model I think I have in my picture is one of the older models. It's one that we used to use in the hospital when I worked inpatient in the hospital, which was about 9 years ago. So there's probably better looking ones that are easier to use now that are out there. So the cough assist machine is an airway clearance device, meaning it's not going to like give you volume of air or anything, but it just helps you to clear your airways to make you breathe easier. So it simulates a natural cough by applying positive pressure to fill your lungs, and then it uses a vacuum-like suction to pull everything back out. So it let's see. I'm just going to see what my next slide is. Okay. Oops, sorry, I didn't mean to go that far. Okay, I'm going to leave that there. So the cough assist, what it does, it has a mask. So it has the device, and then it has a long tubing that comes off of it, and then it has a mask similar to the mask that I was talking about that we can use during the spirometry. So the mask, okay, I was able to go back. So the mask kind of covers your face, and then the cough assist has pressure. Someone from a home care company would come out and they should show you how to use it. And then they set the pressures in there to something that is comfortable for you, but also something that will actually make it work well. And so what it does is it pushes air into your airway pretty quickly over 1 or 2 seconds. And then it uses the vacuum-like suction and it just pulls that air right back out. So a lot of people will try and cough or make a coughing motion with the vacuum-like suction with the exhalation part to make it a little bit stronger. So it pushes the air in, and then right away as it's gonna pull it out, you can kind of create a coughing motion with it to make that vacuum-like suction a little bit stronger to pull out, hopefully move around secretions and kind of bring them more towards your mouth so you can get rid of them easier that way. And people will usually keep the mask on your face for about 3 to 5 rounds. So it's not as helpful just to do one and kind of be done with it, but you want to keep it up there for about 3 to 5. So it'll push the air in, pull it back out, and then pause for a second or two. And then it'll do the same thing again, and it'll pause and then do the same thing again. And so they have found it more useful to do a few of these at once, just to kind of get stuff moving a little bit better than just doing one at a time. So it can be used regularly, morning, night, before meals, things like that, or you can just use it as needed if you feel something in there that you want to get moving. So each session, I said, typically lasts about 5 to 10 minutes because you're doing more than one of those maneuvers at a time. So just to kind of get stuff moving, you do kind of have to spend a little bit more time with it. Okay. So the benefits of the cough assist, it'll try and keep your lungs clear by just kind of moving secretions around that you're otherwise unable to move yourself. It reduces the chance of infection because you don't want those secretions to get into your lungs, and then you can't kind of control them, and they can get infected that way. It can also strengthen your diaphragm by kind of pushing that air in, and then with you coughing with the maneuver, you have to create a little more pressure to exhale like that. So it can actually help with the diaphragm a little bit. Okay. And then my last piece of equipment here is the non-invasive ventilatory support. So we call this NIV support. And it's non-invasive, meaning it's on the outside of your body pushing air in, and it's not going into your body like a trach or something like that otherwise would. That is invasive, but these machines are non-invasive because it's just staying outside of the body. So the non-invasive support would be like a CPAP or a BiPAP, something like that. So a CPAP, I don't have this on the screen, but a CPAP is continuous positive airway pressure, and it mainly just it's used for sleep apnea, things like that, and it mainly just pushes air in to your airways while you sleep continuously, so you don't have to work so hard to get that air in, but it's not helping you get it out or anything like that. So it's mainly just pushing the air in. Then there's the level of a BiPAP, which just adds a little bit more support than the CPAP. So the BiPAP helps push air in, but also helps you get that air out as well. It doesn't breathe for you by any means. You're still breathing on your own. It's just making it a little bit easier and giving you a little bit more pressure and volume when you do breathe while you're sleeping, to lower your work of breathing on your own. And it makes you, for cases of sleep apnea, it makes you stay breathing overnight. But the mode of non-invasive ventilation that we recommend most with is called AVAPS. So it's average volume assured pressure support. So it's not really a pressure. So a CPAP and a BiPAP give you a fixed pressure. So like how the air is coming in, and it just keeps doing that over and over. But the AVAPS actually gives you a fixed volume of air. So it delivers the same amount of air, the volume with every breath, and it gradually adjusts the pressure and things like that to match your current breathing. It adjusts the pressure delivered with each breath changes every single breath to make it more comfortable for you to breathe, is basically how it works. So it's giving you a certain volume of air, but it changes the pressure delivered with that air. So how it's coming in at you with every breath, to make it more comfortable for you to breathe. So it's just a little bit more support, I would say, than the CPAP and BiPAP, and it's generally just a more comfortable way of getting that air, people would say, than the other modes that I just talked about. So the AVAPs, and I think IVAPs, depending on what kind of machine that you use, that they give you from home care, the name of the mode can be a little bit different. I think one of them is called IVAPs instead of AVAPs, but it's generally the same type of support that is giving you with those. So this, I already talked about this. So the modes of ventilation, CPAP, BiPAP, and AVAP. CPAP is just a single pressure that's delivered into your airways. The BiPAP is a double pressured airway, or the bi, and it's the pressure delivered inhale, and then it also helps you exhale the air as well. But the AVAP, the volume delivered changes with the pressure changes with the volume. So it is generally just a more comfortable way of breathing with those machines, because I know sometimes they can get really hard to get used to. So the benefits to the non-invasive ventilation, it can rest your lung muscles. So even though you feel like maybe you feel like you're not working so hard to breathe, but your muscles are generally working a little bit harder than they otherwise were. So it can help rest those muscles. These machines aren't breathing for you, but they are just providing you with a little bit more support to get that air in and out, and it'll lower your work of breathing. It can be more comfortable during sleep, just because you aren't working so hard to breathe while you're laying down. And if it was hard to sleep in certain positions, the machine might make it more helpful to sleep in those positions than it was. It can also improve your fatigue during the day, because you're getting more restful sleep at night, and that should give you a little bit more energy during the day. So the machines come with different kind of masks. So I think the main mask that they start you out with is the one seen on the left here, the full face mask, where it covers your nose and your mouth. Some people really like that. But especially if you're a mouth breather, that is probably one of the more main ways to go. But there are some different options, and I think they let you exchange the mask like every so often, once within the first 30 days or something, and then you can do it maybe a little while later. I'm not too sure on the rules from the home care companies, because I know they can differ, but I know they let you exchange once in a while. So the nasal pillows, as seen in the middle one, is kind of just something that sits on the end of your nose, and it pushes the air in and out that way. It's not covering your mouth. So if you are more of a mouth breather, sometimes they'll try, you can see it in this picture, but there's a strap going under the chin, a chin strap, and that can try and hold your mouth closed while you're sleeping. So you're not, if you are more of a mouth breather, that air isn't escaping through your mouth, which would make the machine not work as well as it should. So the nasal ones just kind of sit at the nose, but you can try a chin strap with that as well. And then on the right, there's one, it's just a nasal mask. So it's kind of the same shape as the full face mask, but it just goes around your nose and not your mouth. And I think there's another one that goes around your nose, or it sits at the edge of your nose and covers the mouth as well. I don't think I have that one on here, but that one is an option as well. Okay. I think that is all I have. So now